Welcome to the exciting world of billing and coding. This behind-the-scenes administrative component is a part of almost every patient encounter that you will have as a PA. Not only does it reflect what occurred during a patient encounter, it also dictates how much you get paid or reimbursed. Knowledge about this topic will serve you well in your career as a PA so that you can understand how to generate revenue. In other words, it establishes your worth as a PA. So let's begin. Our goals with this PowerPoint are to introduce you to the basic tenets of medical billing and coding, to help you understand how this process has a direct effect on providers and patients alike, and to reduce the learning curve that you will undoubtedly have in clinical practice when it comes to billing and coding. Rest assured that many practices will send you to a billing and coding course. This will certainly help. Don't be like most providers, however, and assume that your billing department handles everything and you don't need to know about it. Understanding the basic concepts of billing and coding will serve you well in your clinical practice. For complete disclosure, none of the information presented to you in this PowerPoint will be tested on your pants. However, it will be on your paycheck because this is how we as PAs generate payment. So pour a cup of coffee and pay attention. The details presented to you here will help you get employed, stay employed, dispel misinformation about billing and coding, demonstrate your value and productivity to a practice, show your ability to treat patients and understand payer policies, and help you practice within the law. Let's start with the term billing. Billing is defined as the process of submitting and following up on claims sent to insurance companies for payment of services rendered by a healthcare provider. This is depicted on the bottom left-hand side of the graphic on this slide. This is essentially the part of the process that involves the practice or hospital asking for payment from the patient and/or insurance company. The same process is used by all carriers, but each carrier may have their own guidelines of payment processing. Medicare is frequently the standard by which most other insurance carriers establish their guidelines. So let's look at Medicare a little closer. According to Medicare, PAs must have graduated from an accredited PA program, pass the PANCE, and be state licensed in order to bill for patient services. Once those criteria are met, a PA must establish a National Provider Identification Number, or NPI number for short, through Medicare. This number allows a patient to order tests, refer, and/or bill for services rendered. It's important to note that PAs must enroll with Medicare with respect to every employer. Every time a PA gets a new job, he or she must enroll with Medicare. If he or she has more than one job, he or she must enroll with Medicare with respect to each employer. The NPI number is unique to every clinician. Once a PA has an NPI number, he or she can begin billing for services rendered within the scope of practice, which is determined by Medicare regulations or conditions of participation, state law, hospital guidelines, and supervising or collaborating physicians. Remember that the laws and regulations of a hospital may supersede that of state law, as hospitals or practices sometimes have stricter guidelines than the state legislation for billing. The PA can bill directly using his or her own NPI number, but it's important to note that non-physician provider billing differs from physician reimbursement. Here we define scope of practice, which is essentially what a non-physician provider is allowed to do as designated by government statutes. In addition to the scope of practice, a PA often has a practice protocol in place which provides even more definition of one's job duties and responsibilities as well as competencies. As the diagram to the right portrays, an individual may perform only those job duties for which he or she is educated, certified, licensed, and credentialed to do, meaning you have to have PA training, NCCPA certification, State Board of Medicine approval, and institutional credentialing for everything in your day-to-day job description. If you are performing those duties, you can bill for them. But here's the catch. Not all carriers accept NPI numbers for PAs and NPs. This is continuing to evolve, but some providers accept both NPs and PAs, others do not recognize either NPs or PAs, and still others accept one but not the other. This does not mean that you cannot see patients from those providers that don't accept or enroll PAs. It simply means you cannot bill using your personal NPI number from them. Instead, you would bill under the supervising physician's name and NPI number. As you can see, there are several states in which Medicaid in particular does not enroll PAs, but this is in the works to change. Know that in addition to our large government payers, we also have commercial payers such as United Healthcare, Anthem, and Cigna. These private payers may make their own rules in terms of payment. Some choose not to enroll PAs and instruct the practice to bill under the physician's number, as I previously mentioned. The billing methodology must be clearly ascertained by every practice for each payer with whom they contract. This is usually accomplished within one's administrative or billing department within a practice. Why does it matter if a particular payer accepts a PA's NPI number or requires that of a physician? Well, reimbursement percentages for PAs and NPs vary from carrier to carrier, and in regards to Medicare and some other carriers like TRICARE, non-physician providers receive 85% of the physician's fee schedule for the same service if they use their own NPI number. With that being said, there are provisions for 100% fee schedule for PAs and NPs, such as incident to billing in the office and shared visits in the hospital setting, but specific rules apply. Once you get out into practice, your employer will likely send you to a billing and coding course, which is several days, yes, days, of learning about the intricacies of incident to and shared visits. But for now, let's just know that different providers can get paid different amounts by different insurers for doing the exact same thing. How they determine how much you get paid overall is based on that NPI number. But there's more to the equation than just who you are. There's what you actually did during an encounter. This brings us to coding, which is depicted on the right-hand side of the graphic. Medical coding is defined as the transformation of narrative descriptions of diseases, symptoms, injuries, and healthcare procedures into numeric and/or alphanumeric designations. In other words, it's taking your medical documentation from a patient encounter, yep, all that training on SOAP notes will come in handy, and then transferring it into specific codes that designate everything from the patient's diagnosis to the procedures performed. This is when we get into the alphabet soup of coding. We start to use the alphanumeric combinations to boil down the content of our patient encounters into an evaluation and management code. These E&M codes are one of the several types of CPT, or current procedural terminology codes, that you can see listed on the right. These codes are developed and maintained by the American Medical Association and are used to provide a common language to describe and document services provided. They are used for billing purposes. The CPT coding books are published annually and usually exceed 1,500 pages. They are chock full of numeric 5-digit codes which cover virtually every service or procedure that you can provide. These CPT codes are constantly being updated. Currently, there are over 8,000 codes in use. Think of the CPT codes as telling an insurer what was done in a specific patient encounter. The other side of that is the ICD-10 code, which tells you why you did what you did. In other words, it tells you the diagnosis or diagnoses that you addressed in. We previously used the ICD-9 format, but this has recently been retired, and the ICD-10 system is now in use by every industrialized country in the world. ICD stands for International Classification of Diseases, and the code describes the patient's symptom, condition, complaint, or problem. It justifies medical necessity. If you look at the designation of ICD-9 formatting and compare it with the ICD-10 on the You can see that the ICD-10 format allows for many more codes. In fact, the number of potential usable codes increased from 14,000 to 69,000 with the switch from ICD-9 to ICD-10. ICD-10 designations allow for greater specificity of diagnoses. It now distinguishes initial versus subsequent encounter and where precisely on the body care. Here you can see the changes in a side-by-side comparison of ICD-9 codes versus the new ICD-10 codes that are in use. And here you can see that for an insect bite, we've gone from 18 codes with ICD-9 to more than 87 to choose from with the ICD-10 designations. Here are some golden rules when it comes to assigning ICD-10 codes for a visit, which, by the way, are usually available in EMR systems as a keyword search in a drop-down menu format. Number 1, never assign a diagnosis code for an unconfirmed diagnosis. If you are not sure and you are using words like probable or suspected or questionable for a diagnosis, you need to use the symptoms for coding, not the presumed diagnosis. This is especially true for conditions that may detrimentally impact a patient, such as epilepsy, which may result in losing the ability to drive a car, or potentially things like psychiatric diseases, cancer, and infectious diseases. Next, know that a condition that has been ruled out is never. Next, always document and code to the highest level of specificity and make sure that your documentation supports the coding. Keep in mind that ICD-10 codes are simply one piece of the coding puzzle. We have to use the appropriate diagnostic codes to link the history and physical exam with the plan of care. Remember that the payer, the insurance company or individual that is receiving a bill for your services, does not have the chart, the patient's perspective, or the ability to talk to you about each patient, so correct coding communicates the details of an encounter to the payers. The Centers for Medicare and Medicaid Services, which is known as CMS, has put together a resource on coding, and in it there is an excerpt that you see here. They begin the entire 90-page manual with the general principles of E&M documentation that you see here, which state, if it is not document, it has not been done. Clear and concise medical record documentation is critical to providing patients with quality care and is required for you to receive accurate and timely payment for furnished services. Remember that your goal in every encounter is to have reasonable documentation, medical necessity for everything that was performed, and accurate. General principles of medical record documentation apply to all types of medical and surgical services in all settings. While E&M services vary in several ways, such as the nature and amount of physician or clinician work required, these general principles help ensure that medical record documentation for all E&M services is appropriate. The medical record should be complete and legible. The documentation of each patient encounter should include the reason for the encounter and relevant history, physical exam findings, and prior diagnostic test results, the assessment, clinical impression or diagnosis, the medical plan of care, and the date and legible identity of the observer. If the rationale for ordering diagnostic and/or other ancillary services is not documented, it should be easily inferred. Past and present diagnoses should be accessible to the treating and/or consulting clinician. Appropriate health risk factors should be identified. The patient's progress, response to, and changes in treatment and revision of diagnosis should be documented. The diagnosis and treatment codes reported on the health insurance claim form or billing statement should be supported by documentation in the medical record. To maintain an accurate medical record, document services during the encounter or as soon as practicable after. But remember, in addition to your friendly coders, the patient, attorneys, and auditing payers may also have access to your notes, so make sure to be thorough yet appropriate in your documentation. Now that we understand the basic process of coding and billing and the general components involved, let's take a look at how a code is actually generated. Many of you might be thinking, I don't need to do this. There's a coding department full of certified coders that can handle this. Well, that is usually the case, especially in larger practices and hospitals, but in many practices, you, as the provider, are expected to establish the E&M code for the visit before closing the chart. Additionally, understanding the process will help you understand how much revenue you generate for the practice and in turn helps you prove your worth and value as a PA. Lastly, understanding the process will enhance your documentation ability as you will soon see that what is documented is directly linked with what you get paid for. Billing for an E&M service requires the selection of a CPT code that best represents patient type, setting of service, and level of E&M service provided. Let's start with the patient type. For purposes of billing for E&M services, patients are identified as either new or established, depending on previous encounters with the provider. A new patient is defined as an individual who did not receive any professional services from the physician or non-physician practitioner or any other physician of the same specialty who belongs to the same practice within the previous 3 years. An established patient is an individual who received professional services from the physician or non-physician provider or another physician of the same specialty who belongs to the same group practice within the previous 3 years. Thus, if a patient is new to you but has been seen by another physician or PA within your practice within the past 3 years, they are not considered a new patient. They would only be a new patient if they have not been seen by anyone in your practice in the past 3 years. For the setting of service, E&M services are categorized into different settings depending on where the service is furnished. Examples of settings include office or other outpatient setting, hospital inpatient, emergency department, or nursing facility. Then comes the level of E&M service. The code sets to bill for E&M service are organized into various categories and levels. In general, the more complex the visit, the higher the level of code you may bill within the appropriate category. To bill any code, the services furnished must meet the definition of the code. You must ensure that the codes selected reflect the services furnished. The 3 components when selecting the appropriate level of E&M services provided are history, physical examination, and medical decision-making. Visits that consist predominantly of counseling and/or coordination of care are an exception to this rule. For these visits, time is the key or controlling factor to qualify for a particular level of E&M services. Here you can see the most common E&M codes broken down by setting and patient visit type. In the bottom right-hand corner, you can see a coding worksheet. You will become intimately familiar with this coding worksheet as we will be using a worksheet just like this on every encounter for which we code in this class. There are many worksheets or tools out there to help with coding. This is simply one example that tends to be straightforward, which is why we use it. Prior to using these worksheets in our coding workshop, let's talk about the basic aspects of the visit that we need to understand: history, examination, and medical decision. The history will be categorized as either problem-focused, expanded problem-focused, detailed, or comprehensive. Note that all 4 elements in a row must be met to satisfy the particular type of history. Please note that problem-focused is not the same definition that you use in your Clinical Assessment 3 class. The coding definition of a problem-focused visit is very specific. In all of these types of a history, you need to include a chief complaint. This is a concise statement that describes the symptom, problem, condition, diagnosis, or reason for the patient encounter. The chief complaint is usually stated in the patient's own words. For example, patient complains of upset stomach, aching joints, and fatigue. The medical record should clearly reflect the chief complaint. The HPI should include the OPQRST details or 7 attributes of the illness or presenting issue. The 2 types of HPIs are brief and extended. A brief HPI includes documentation of 1 to 3 HPI elements. In this example, 3 HPI elements, location, quality, and duration, are documented on the left-hand side. An extended HPI requires 4 or more elements of the present HPI. In this example, we can see that there are 5 HPI elements covered: location, quality, duration, context, and modifying factors. Then we come to review of systems. The 3 types of ROS are problem pertinent, extended, and complete. A problem pertinent review of systems inquires about the system directly related to the problem identified in the HPI. In this example, one system, the ear, is reviewed. An extended review of system inquires about the system directly related to the problem or problems identified in the HPI and a limited number, 2 to 9, of additional symptoms. A complete review of systems inquires about the systems directly related to the problems identified in the HPI, plus all additional, which is a minimum of 10, organ systems. That means you must have a total of 11 systems covered. You must individually document those systems with positive or negative responses. For the remaining systems, a notation indicating all other systems are negative is permissible. In the absence of such a notation, you must individually document at least 10 systems. Here's an example of a complete review of systems. We then lump the remaining history, the past medical, family, and social history, into a group called PFSH for past, family, and/or social history. The 2 types of PFSH are pertinent and complete. A pertinent PFSH is a review of the history areas directly related to the problems identified in the HPI. The pertinent PFSH must document at least 1 item from any of the 3 history areas. A complete PFSH is a review of 2 or all 3 of the areas, depending on the category of E&M service. A complete PFSH requires a review of all 3 history areas for that service that by their nature include a comprehensive assessment or reassessment of the patient. A review of 2 history areas is sufficient for other services. Now, you don't need to re-record a review of systems and/or a PFSH item obtained during an earlier encounter if there is evidence that the clinician reviewed and updated the previous information. This may occur when a clinician updates his or her own record, or in an institutional setting or group practice where many clinicians use a common record. You may document the review and update by describing any new review of systems and/or PFSH information, or noting there is no change in the information, or noting the date and location of the earlier ROS and/or PFSH. Ancillary staff, such as nursing staff, may record the review of systems and/or PFSH. Alternatively, the patient may complete a form to provide the review of systems. You may provide a notation supplementing or confirming the information recorded by others to document that the clinician reviewed. If your head is spinning, don't worry. You don't have to remember any of the details I have just reviewed because your handy-dandy coding worksheet outlines it all for you, as you can see here. During our workshop, we will use some sample notes to determine the appropriate history level. So that covers the history. Then comes the examination. An examination may involve several organ systems or a single organ system. The type and extent of the examination performed is based on clinical judgment, the patient's history, and the nature of the presenting problems. Believe it or not, the last time the physical exam documentation guidelines were updated was in 1997. So there are 2 guidelines out there, both of which can be used, but you cannot combine the 2. Pick one or the other when it comes to the physical exam. The 1995 version deals with organ systems or body area, and the 1997 guidelines use bullet points. Essentially, either one of these guidelines is used to determine how detailed the physical exam is. It can be either problem focused, expanded problem focus, detailed, or comprehensive. Here you can see the differences between the two guidelines. We will go into more detail with this during our upcoming workshop. These important points are taken directly from the Medicare E&M manual, and they should sound very familiar to you. It is similar to what you have heard in clinical assessment. You must document specific abnormal and relevant negative findings of the examination of the affected or symptomatic body area or organ system. A notation of abnormal without elaboration is not sufficient. You also must describe abnormal or unexpected findings of the examination of any asymptomatic body areas or organ systems. This is the visual of the examination portion of our worksheet that we will be using. This is based on the 1995 guidelines. And finally, the final step, medical decision making. Medical decision-making refers to the complexity of establishing a diagnosis and/or selecting a management option, which is determined by considering these factors: the number of possible diagnoses and/or the number of management options that must be considered, the amount and/or complexity of medical records, diagnostic tests, and/or other information that must be obtained, reviewed, and analyzed, the risk of significant complications, morbidity, and/or mortality, as well as comorbidities associated with the patient's presenting problem, the diagnostic procedures and/or the possible management options. This table depicts the elements for each level of medical decision-making. Note that to qualify for a given type of medical decision-making, 2 of the 3 elements must either be met or exceeded. There is an entire page dedicated to this on our coding worksheet. Let's break that. First, we have the number of possible diagnoses and/or the number of management options to consider, which is based on the number and types of problems addressed during the encounter, the complexity of establishing a diagnosis, and the management decisions made by the clinician. In general, decision-making for a diagnosed problem is easier than decision-making for an identified but undiagnosed problem. Problems that are improving or resolving are less complex than those problems that are worsening or failing to change as expected. Another indicator of the complexity of diagnostic or management problems is the need to seek advice from other healthcare professionals. Next is the risk of significant complications, morbidity, and/or mortality. The risks associated with these categories are based on the presenting problem, the diagnostic procedures, and the possible management options. The assessment of risk of the presenting problems is based on the risk related to the disease process anticipated between the present encounter and the next encounter. The assessment of risk of selecting diagnostic procedures and management options is based on the risk during and immediately following any procedures or treatment. The highest level of risk in any one category determines the overall risk. Then we have the amount and/or complexity of the data to be reviewed. This is based on the types of diagnostic testing ordered or reviewed. Indications of the amount or complexity of data being reviewed include a decision to obtain and review old medical records and/or obtain history from people other than the patient, which increases the amount and complexity of data to be reviewed. Discussion of contradictory or unexpected test results with the physician who performed or interpreted the test, which indicates the complexity of data to be reviewed. The physician who ordered a test personally reviews the image tracing or specimen to supplement information from the physician or clinician who prepared the test report or interpretation. We then put all of these individual components together for the history, physical exam, and medical decision making and end up with a specific code based on the setting in which we have seen the patient and the type of patient encounter, which is new versus established. Easy, right? Trust me, it will make a lot more sense when we go through some examples in our workshop. In the meantime, I encourage you to take the time to review the worksheet that is posted in Blackboard. The more familiar you are with how it is broken down, the easier you can use it. Although overwhelming at first, coding and billing will become second nature to you and will serve you well in your career as a PA if you make an effort to align your clinical practice with your documentation and your associated charges. It all boils down to documentation, so remember to diligently document what you do in a patient encounter. Thanks for listening and for stepping into a new dimension of medicine. I do not expect you to be a professional coder anytime soon, but I do want you to start understanding the process and what goes into it. The more you know, the more valuable you will become as a PA. One last thing, remember to bring a highlighter and a pen or pencil with you to class for our coding workshop.